Hey YouTube, it's Marita from the Nurse Lounge, and you're probably wondering where have I been for the past, say, month. I have been busy with school, with my clinicals, with my work, and with the kids. So I really haven't had, well, that's not true. I have had time to record. It's just that I've just been lazy. I've been tired from doing those things. So I'm going to not belabor this and go ahead and jump right into this video. This video is requested by a subscriber or an IG follower, or maybe both. I'm not sure which she was. She may be both. But the video she wanted was how to stay organized or how to prioritize at work. So I wanted to actually take you to work with me and kind of show you kind of how I do that. And I may still do that one day in the future. However, just to get this video out, I will kind of talk through what I usually do. And when I do get a chance to work, I will probably take you along and kind of show you snippets of how I stay organized at work. So I do have notes here, so I will be looking down from time to time. But again, the video is basically going to be about how I stay organized, how I prioritize, how I cluster my care at work. This is pretty much step by step to a certain extent, but be mindful that this is my routine. So I'm not expecting you all to go do my routine at your job, because your job may have certain policies or scheduling that does not reflect what mine does. So I'm doing this based off of the scheduling at my job. You can just kind of govern yourselves accordingly to what you do at your job. So I have a kind of a list, this step by step. I will be reading from this list, but and I will tell you the modifications that you can make along the way if something that may fit better in your situation than mine. In case you don't know, I am an OB nurse, or mother baby, or I do mainly postpartum, antepartum, GYN surgeries. I do get floated to nursery from time to time, and we do get floated to labor and delivery to do one-on-one patients and post-recovery patients. But this is basically on my postpartum units, what I'm talking about on this video. And some of this may apply to med surg. You can transfer it into another department or another specialty, but a lot of it won't, because of the fact that your scheduling will vastly differ from my scheduling. So first thing I have on here is getting organized actually starts before your shift. So if you work day shift, it starts the night before. And if you work night shift, it starts that day. So what I mean by that is making sure you get adequate enough sleep, because if you're tired, your ability to function and go about moving and taking care of your patients properly is going to be inhibited. So make sure you get as much sleep as you possibly can the night before, the day of your shift. That's very, very important. When it comes to night shift specifically, it's very hard to sleep during the day. So you may have to get you some night blinds. You may have to take some Benadryl, or whatever you typically have to do in order to be able to function, or actually not function, but get you some sleep at during the day for your night shift. The next thing is to arrive on time. I cannot tell you how many times if I arrive late, it kind of makes my day discombobulated the entire day. So it's very important for you to arrive on time for your shift. We have to be at work at 6:45 in terms of when shift change starts at 6:45 in the morning. And I do work day shift, so from 6:45 to 7:15 at night is my schedule. That's pretty much when I clock in. I'm not one, now I did say to arrive on time. If you arrive at 6:45, technically you're late in my book. But again, that's one of those things where it's like, do as I say, not as I do. I'm not giving that hospital no more of my time. So I usually clock in right at 6:40, between 6:40 and 6:43, so that I can get report. But when I do come in at 6:45, which is right on the dot, I come in ready to take report. So when I clock in at 6:45, I'm coming down the hallway with my clipboard and my pen in hand, so I can go ahead and get report from the nurses so they don't have to wait on me. I'm not one to come in at 6:45 or 6:50. I'm like, I need to get my coffee. I need to do this, that, and the other. I'm not that kind of nurse. So if I'm going to be barely making it, I'm going to make sure that I basically have my pen in my clipboard and my paper in hand so that I can go ahead and get started with report. The next thing I have on here is get a good report. So you know how nurses are. Sometimes we give great reports and sometimes we don't. But if you are familiar with your unit and you're familiar with the kind of patients that you have, getting a good report is of paramount importance for you to stay organized and to kind of govern yourself during the day. How many times have you worked, I know I have, where I have gotten a report, a bad report, shall I say, and then you find out things along the way, or better yet, you find out things when you give a report to the next nurse that like that would have been helpful to know all day long as to why this patient is acting the way she is or whatever the situation may be. So get a good report. And if they are a bad report giver, then it is your responsibility to ask questions. So for instance, when I get report on my patients and I have a C-section patient that I'm getting, or even when I get report from labor and delivery to me, I will say things like, okay, so have you given any medications, in case they haven't told me? A lot of times I want to know what have you already given so that when they come over to my side, I'm not having to look that stuff up. That's what a good report giver would tell you. I'm like, does she have on her SCDs already? How much did you empty from her Foley? And if nothing else, it will prompt you to say, oh, if nothing else, it will prompt you to ask those questions, and it prompts that other nurse who's giving a report to say, oh, I did not do that. Let me go back and do that. Or if nothing else, it helps you check that nurse and say, you know what, that you expect that to be done before the patient comes over to you. So, or if it's a change of shift where it's I might change of shift. It was a report where it's just from day to night or night to day. So the patient's already on your unit. It's like, oh, did you do X, Y, and Z? You're kind of checking off their boxes too. Did you take the Foley out? Did you do the pericare? Did you get your patient up or whatever happens to be? And then also a good report allows me to know where I need to take over from. So make sure you ask questions. If you're not asking questions and then you get stuck with the situation, it's kind of on you at that point. So you have to kind of start behind the 8 ball and kind of figure out how can I get caught up here. And again, that's part of the time management. So if you're coming behind a bad nurse, already mentally know that he or she who you're following, if they have they're habitual about making sure that their patients are not taken care of, you already know that you have to do extra work when it comes to that patient. So ask questions, get a good report. The next thing is, if your time allows, go ahead and eat or get your coffee. At my job, we don't have time to go eat. Well, I'm not coming any earlier than 6:45. So in terms of going to eat or get my coffee, I don't drink coffee, but to go eat. So usually in my situation, I go get reports. I ask questions. We do bedside reports. So I go see my patients at change of shift with the other nurse, with the off-going nurse. And so I will ask, well, I don't ask the question, but I will tell my patient at that point in time, I will be back to see you within an hour to hour and a half to start my assessments. So that go ahead and gives my patients a window of when I will return. And I always make sure I do that. I will be back in an hour to an hour and a half to start my assessment that includes your vital signs and your meds. And they're like, okay. So mind you, I tell every one of them that exact same thing. So if I'm seeing them at different times, their hour to hour and a half time will vary. Because if I just left this one patient at 7 and I tell her an hour and a half, that's going to be between 8 and 8:30. But now if I go see another patient at 7:15 doing my bedside report, then that's going to be between 8:15 and 8:30. So you see kind of how that goes. They know to expect me between that time, and they're usually ready for me when I come back. The next thing I have on, and then also keep in mind when you have eaten and when you have gotten your coffee, if that's what you drink, it kind of puts you in a better mood. A better mental state, and basically the energy that you need to go ahead and begin your morning. As you know, majority of the time, the heaviest part of your shift is that initial first few hours when you're doing vital signs, med passes, and assessments, and of course charting, and any ADLs that you have to do for your patients, depending on your patient population. We don't have to do a whole lot of ADLs because our patients are relatively stable, but outside of that, we are pretty much, good to go with ADLs. I do remind them to shower and things like that, but it's very rare to do anything like that for them. So be mindful of that. Okay, so the next thing I have on here is I kind of, and this may differ per floor that you're on, but for me, if I'm usually not the charge nurse because I'm PRN. So I always like to know which admission am I? So what does that mean? So we usually have about 3 to 4 nurses working at a time. Well, 2 to 4, really depends on our census. Just as a breakdown, this has nothing to do with the video, but just so as a breakdown so you understand what our ratios are for my facility. We have a ratio of 1 to 6. So therefore, when we get to 13 patients, we get the 3rd nurse. Then when we get to 19 patients, we get to fourth nurse. So depends on, what our census is to determine what admission you would be. If we only have 6 patients. Now, with that being said, it's a 1-to-6 ratio, but we always have 2 nurses on the floor no matter what. So if there's only 2 patients on the floor altogether, we still have 2 nurses on the floor. You just get 1 patient each, if that makes sense. Which, for safety reasons, I think that's great that we do that. Budget-wise for the hospital, that's not great, but for safety, it's wonderful. So we always have two nurses on the floor no matter what. If we have 1 patient, we have 2 nurses taking care of that 1 patient. We just kind of switch out who's going to do what. Makes for a long shift, but I'm glad for safety reasons we do have that. But anyway, back to what I was actually saying. So I want to know what admission that I have. So that helps me get organized personally. So if we have, here lately we've been having 3 nurses. So I want to know, do I have first admission, second admission, or third admission in my situation? So if they say, well, you have first admit, that means the first person who delivers, if they have not already delivered, I'm getting that patient. So I got to add that on into my scheduling for the day, more organization for the day. If I'm getting second admission, that buys me a little bit more time unless we already have 2 patients already delivered, if that makes sense. So when I say already delivered, that means they are in labor and delivery currently. However, they have already had their baby and the recovery period is actually over at that point in time, and they're just ready to come to postpartum. Sometimes they don't come within the 2-hour time frame because it's change of shift, and we at our hospital do not do admissions at change of shift. So if you deliver at, say, 4:30 or 5 o'clock in the morning or afternoon, you will stay in labor and delivery until change of shift. So that means your recovery time will extend into, say, 3 to 4 hours until the next shift comes in, and then we bring the patient over at that point in time. So you can understand if I had a patient who is already delivered and I'm first admission, that phone is going to start ringing pretty much as soon as report is over. So I need to be ready. That means sometimes I can't go eat breakfast because guess what? I have the first admission. I personally cannot stand, and I can't emphasize this enough, when I pick up the phone and it's like, we're ready to give a report, and the charge nurse is telling me, oh, this is your patient. Well, when was you planning on telling me this? I like to be organized. I like to be ready. I don't like have to call my nurse, call L&D back and says, I'll call you back because I didn't know I was getting the first admission and I got to go set this room up. I like to have everything ready. That's just the kind of nurse that I am. So I want to know, what admission do I have? First, second, third, or however your facility goes, fourth, fifth, whatever happens to be. And then as you know, it rotates back around. So if I have, if it's first, second, third admission and I have first admission, well then I have first, the other 2 nurses have second and third. So the 4th person who comes is back on me again, and 5th and 6th and so forth. So I always like to know how many patients I have, what admission I am. So it helps me mentally and physically prepare to receive that patient and to receive them in a timely manner in which I'm not making them wait to stay in labor and delivery when it's time for them to come to postpartum. So that's very important for me to know. I suggest you ask that question too to your charge nurse, which admission am I? And then sometimes they may say, oh, I don't know, we don't do it that way or whatever. I think a good charge nurse, what makes a good charge nurse, and maybe I should do a video on that. If you want to see a video on what makes a good charge nurse, definitely leave a comment below or thumbs this up and let me know you want to see a video on what makes a good charge nurse. But anyway, a good charge nurse, one thing is he or she should be able to tell you which admission you're going to be. They should be that organized that helps their staff or their team to be organized so they can prepare for their, to have a great day. That just kind of helps you have a great shift, and that's what you need. The next one I put on here is, unless urgent, before I see my patients, I actually get organized. So what I usually do at that point in time is, if you're familiar with report sheets or sheets that nurses will use, either that they have made themselves, that they have printed offline, or that whatever they have done, borrowed from someone else, that helps them organize their patients for that day and organize their care for that day, then get you a sheet like that. Me, I just create mine. I just simply get a sheet of paper from the copier machine. Just get me a plain sheet of paper from the copy machine, and I write on there the patient's room, their last name, how they delivered, was it a vaginal delivery? Was it a C-section? I put on my sheet, we do vital signs at 10, 2, and 6. So I put on my sheet, vital signs. If I put 10, 2, and 6, that means I have to do vital signs at 10, 2, and 6, and I do fundal checks at 10, 2, and 6 as well. If I only put 10 o'clock, or if I only put 10 and 6, that means they don't have vital signs but twice that shift or whatever. If I only put 10 o'clock, that means they're going to be discharged today because of the fact that they won't be here at 6 o'clock to get their vital signs done. So that's kind of how I mentally can look at my sheet to know who needs 2 o'clock vitals or midday vitals, who needs evening vitals, which all our patients need evening vitals, all of them need morning vitals. But that middle set of vital signs and fundal checks, we don't have to do if they are over 24 hours postpartum and there are no other issues regarding their blood pressures or their temperatures or their bleeding or things like that. So I'm very good about making sure that I can like just eyeball my sheet of paper and say, okay, they only need vital signs twice this shift, 3 times this shift, or whatever it happens to be. So I always write that stuff down. I always, if you do make your own or if you're looking for one online, make sure it has the key features for what you need for your unit. Meaning, does it, there's a certain labs that you all always have done for your patients, for pretty much all your patients. For us, it's hemoglobin, hematocrit, WBCs, or not WBCs, a CBC with diff. So H&H, we have that done sometimes separately. And then we have CBC with diff typically done. And those are the biggest ones we have. Now, mind you, if you have a special circumstance, like I had one this past week who had potassium and we had to draw her potassium levels because that was just different for us. So that wouldn't be on my pre-printed sheet, but that's something I would add and probably highlight that I need to pay attention to because that's something we typically don't do. So it should have on there like your labs, the diet they're on. Like for us, it's either clear or regular diet or MPO. Our vital signs and times, like I told you, mine is 10, 2, and 6. But I will say this, even though our vital sign times are 10, 2, and 6, I do not wait until 10 o'clock in the morning to get my first set of vitals. I do my vital signs with my morning assessment. So that one is done very early because I need a whole picture of my patient. So I'm not gonna do my assessments at 8 o'clock in the morning and then turn around and wait till 10 o'clock in the morning and come back and do vital signs. It does not allow me to have my whole picture of what's going on with my patient. Plus, for me, I don't give narcotics unless I have a baseline vital sign that I did. I don't go off what the previous shift just told me. I do what my own vital sign. So again, it's supposed to be done at 10, but I do them very early because I want to know what my baseline vital signs are and I want to get a picture of my whole patient, what's going on with her. So vital sign times, your I's and O's, your patient's history, their allergies, IV stuff, IV sites, what they are, what gauge, what's running in it. We usually have 18 or 20 gauge IVs. We usually put most of ours in the hand or wrist or arms. We don't usually put them in the AC. When they come from ER, they come in the AC or whatever, but outside of that, we usually all put them in the hands or wrist or upper arm type of area. And then what kind of fluid we have. And this is just to name a few. So you may have to tailor your sheet if you're making your own to what's pertinent to your floor, but that's what's pertinent to our floor. So I'm always big on writing down, in my case, how they delivered, what time they delivered, because that tells me based on the date and time, how often I have to do those vital signs and fundal assessments. I put down any pertinent information or special things about them that's different from what we typically do. So if this person is a redhead, which is a big deal for us because it increases, for whatever reason, their DNA setup just impacts their bleeding and things like that, then I will put, an asterisk or something by it so I'll know I need to check on her bleeding more often. Even if she's doing okay, I always kind of go back and check, how is your bleeding doing? Is it okay? Because sometimes it can go away and not be okay. Let's see what else. Okay, I put in here that the next thing I do is look up my meds and their times. So after all that's done, so mind you, I still haven't seen my patients yet besides my morning bedside reporting that we do. I am now sitting down and I'm looking up my meds, and depending on when I was able to get things done, whether I was able to eat or not, I look up my meds. So I'll go patient by patient, look up my meds, look up my labs, look up labs that need to be drawn as well as lab results. So in case the doctor comes by, I can tell them what the results are, or just in case that the patient wants to know something, I can let them know what the results are. So I look up my meds, my med times, I write that down. So every patient, I put down medications, I put the date, not the date, but the time that they have them, and I put them for the entire day. I list it for the entire day because that helps me get organized first thing in the morning. It makes me kind of look at my patient assignment and say, okay, who do I need to see first? What medications? Who's going to be a more difficult patient to care for in terms of acuity wise? What types of things I got to do? Who do I need to call today? What physician I need to call? Do I need to call? I had to call mobile crisis last week. So calling them, and how would I factor all that in, and calling DCS and calling just just getting all these things lined up for this particular patient was cost me a lot of time that day. So again, this video is about how to try to stay on task, time manage, try to get ready for your day, and not really have to, be so far behind. So the next thing I do after I look up my meds and my times, I pull my meds, and every hospital is different about how you go about doing this. I usually will go, in the morning, the only thing we're giving for our patients is typically just Colace and maybe a prenatal vitamin or something along those lines. So I'll go ahead, and if I have 5 patients, I'll go ahead and pull my 5 Colaces if they're all getting it. Now, mind you, it's the exact same medication with the exact same dosage. So I just go ahead, now I charge everybody for their Colaces, but I do pull all 5 at the one time. In nursing school, we're told not to do that. You just pull one, go administer it, pull another, go administer it. For me, that's not time effective because I'm coming back to get the exact same medication 5 times. So for me, what's cost effective, or not cost effective, time effective, is to pull all 5 of my Colaces. It's the same medication, okay? Same dosage, everything. Now, I will say this. You on your med-surg floors or critical care floors, that may not work because you do not want to get anybody's medications mixed up. You don't want to pass, this person's 25 medications to the wrong patient, and they may have similar medications or similar blood pressures or similar doses or whatever it happens to be. So in those types of situations, you do need to pass them one at a time to be safe. In my case, if I'm passing Colaces and it's 5 of them to 5 different people, the same dose, same 100 milligrams, I'm pulling all 5 of them, lining my cups up. And if you've seen some of my videos, you've seen where I've lined my cup up and just drop a Colace in each one because that's what I'm about to give every single patient. So I do that, which again, that may be a little bit unorthodox, but that is how I manage my time. What else do I do? I said, basically to look at your unit schedule and policy to see if this is what you're allowed to do or not. Then next, number 7 is I actually prioritize and see which patient do I need to see first. Now, we all do that very differently. I usually base it off of if somebody's called out for pain medication, well, I'm going to go see them first, obviously. But let's just say, for instance, no one is called for pain medication and it's just time to get my day started. Then I typically look at my medication list and see, is there any special medications that are different, like Lovenox that I have to give? Do I need to do any blood sugars? Do I need to, what else? That's pretty much those types of things. So I need to do something special intervention at a certain time that is time sensitive, then that's who I'm going to see. Sometimes you would think when I have a fresh C-section that maybe I should go see my fresh C-section first. Keep in mind, for me, I've already seen these patients when we did bedside reporting. So I kind of get an idea then about who I need to see first. But I typically save my C-sections, my fresh C-sections, if they're doing okay, for last. Why is that? Because they take more time. So I can go ahead and knock out the other 4. Older patients, in terms of postpartum wise, in terms of how many hours since delivery, I see them first a lot of times to get them done. And then that way I can spend the majority of my time with my C-section because I may need to get her up. So as an example, this past Friday, I worked at the hospital. And I had a fresh C-section that needed to get up, and she had a lot of medications I had to do. I had to empty her Foley. Actually, I had to take her Foley out. I had to clear her IV pump. I had to take her SCDs off. I had to make sure she could do her incentive spirometry, and on, and pass her meds and do her assessment. So I didn't have to do all that with my other patients. So therefore, I just went ahead and did her last. That's an example of why I would do her last. She wasn't sick in terms of throwing up. She wasn't in any pain when we checked on her earlier. So there was not a need for me personally to go see her first, even though she's the freshest patient. And logistically, that makes more sense to see your freshest patient first because they're the more usually higher acuity, more care required. But based on my years of experience, and I've been a nurse for 15 years, but based on my years of experience, that's just not how it works best for me. For my time management, it works best to put her last. That way I can go ahead and knock out everybody else, get them medicated and everything. And then after that, go see her and spend majority of my time with her. And that way I can, do whatever needs to be done and be done with her at that point in time. So then the next thing I put on here is, now that I've figured out who I want to see, it's now time to go see my patients. So when I go see my patients, I walk in, I introduce myself. My name is Marita, and I'll be taking care of you today. I'm your nurse today, which they already knew that really from bedside reporting. But so when I go back in, unless they were asleep earlier, I say, okay, I'm back. Good morning. I'm back. And then by then I'm bringing in my what do we call it? We call it a cow, computer on wheels. So I bring my cow in, my vital sign machine in, and I have my meds and everything with me, and I'm, going to their room. And they know because I just told them that I'll be back within an hour to hour and a half. So they are expecting me. Again, that helps you organize and have them plan and be ready for you when it's time for you to do your assessments and things. So while I'm in there, I do my vital signs, I pass my meds, I do my complete assessment, and I go ahead and get their water at that point in time. So I get everything, my plan is to get everything done at that one point in time so that they will know that they've been fully taken care of. I provide anything else that they need. So before I walk out the room, I'll say, is there anything else I can get for you? Do you need any pads? Do you need to shower today? Do you need any fresh, towels, washcloths, gowns, whatever you need? I try to go and get everything they need so that I don't have to come back and forth all day long into their room for these little bitty things that takes up time. And they're like, oh no, I think I'm good for now, whatever. I always make sure at our hospital when we pass meds. Oh, and that's another thing. I always ask them their pain, of course, with their vital sign. It is the 5th vital sign, but I ask them their pain, and I always check to see if they have medication available that they can take. So I'll say, okay, your pain is even a 3. And if they have a Motrin available, I'm going to say, would you like your Motrin now? And some of them are like, yeah, I think I will take it. I go back and go get their Motrin. And then we have to write our time on the board that they can have it again on our whiteboard. We write down what time they can have that medication again. So that way, and I'll say, this is when this medication is available again. So that way they will know when to call you for that medication when they're ready for it again. So I go ahead and get those medications, those PRN medications, those narcotics that they want. Again, the reason why I have to have my baseline vital signs because I want to know what their baseline is to know, will I really give this narcotic, number one? And number two, will I give them 5 milligrams of Norco or will I give them 10 milligrams of Norco? Because if their blood pressure is 80/40, I really don't want to give either one of them. However, if I'm going to give one, I'm going to give the 5 over the 10. If their blood pressure is 150/90, I'm like, they may be able to do better with the 10, help, bring their pain down. And I'm talking about pain thresholds of like 7 and above, not a pain of a 3. You're not getting a Norco for a pain of a 3, not from me. That's just me. But you all do what you do, but that's just me. I don't give Norco. I don't give narcotics for a pain of a 3. Pain of a 3 at our facility is considered to be acceptable pain. And in case you all don't know, if you've never had a baby before, you will be in pain from having a baby. There is no way to be pain-free from having a baby permanently. You have to go through the healing process, and it's just painful. And I do have to tell my patients that from time to time, that it's just painful. All right, so I always say on there, I kind of give them, after providing them with any of the things that they need, like, like I said, the shower stuff and the pain medications and straws, cups, whatever they need, I then give them my plan for the day. That basically means I tell them, okay, I'll be back at this time to do this. I'll be back at this time to do this. I'll be back at this time to do this. And I kind of give them a rundown about how the day is going to go. And I do that with each patient. So when I come back and it's not a convenient time because I got a room full of visitors, guess what? They know Marita's going to do what she's going to do regardless of who's here. And so they're like, oh, she's coming to do my vital signs. She's coming to do my fundal check. She's coming to check me over real quick. They know that because I've already told them that, first thing that morning, that's what I'm going to do. And every time I go to do that next intervention, I tell them when I'll be back for the next intervention. So for instance, let's just say it's I start my vital signs about 1 o'clock for our 2 o'clock vitals. So let's just say it's 1 o'clock and I'll say, okay, I'm going to start to do your vitals now. And I will be back unless you need me, I will be back between 4 and 6 to do your evening fundal check and vital signs. They know to expect me between 4 and 6. And then when I come back between 4 and 6, I said, if you don't need me, mind you, I'm asking the question, is there anything else that I can get for you? Do you need? And they say no. I said, well, unless you need me, I will not be back until, say, 6:45 or change of shift is usually what I say, to introduce you to your nurse for tonight. That way they know when change of shift comes, I'm bringing in the nurse for tonight so they'll know who's going to be caring for them that night. I basically set them up for success throughout the day so they'll know exactly what I plan to do all day long. That way there's no question as to why I'm in their room. There's no question where they feel like I'm bothering them. I don't feel like that I'm like, forgetting to do things because I've told them what the plan is. Now, Have I forgot to do things? Of course I have. Have I had to go back in the patient's room? I forgot to do something? Of course I have. And by the time you spend so much time going back in there doing things over that you should have did with your assessment that morning. So like, for instance, we have to check for hemorrhoids, and maybe I forgot to check for hemorrhoids. I'm like, dang, I got to go back in there. Well, I got to go do it. But I guarantee you, the more I do things wrong like that, the more I get it right the next time, where I'm like, okay, I can't keep running back and forth in these patients' rooms. I need to go ahead and basically cluster my care and get everything done. All right, so then the next thing I have on here, let me turn the page, is let's focus on the time management aspect. So I always say, try to get as much done as possible. Don't wait. I just said this. Don't waste time going back and forth in patients' rooms. So I literally just talked about that just now. Do not waste your time going back and forth. You will learn as time goes on that you'll get better and better and better at it in terms of clustering your care, what needs to be done. I always try to do example. So let's say I have a medication that's due at 11 and I have another medication that's due at 12. Well, guess what time I'm giving those medications? 11:30. I'm not going to go in at 11 o'clock and I'm not going back at 12 o'clock. I'm going to go at 11:30 and do both of them. Because at our facility, we have a window, an hour window on the front end and an hour window on the back end to pass our medications. But if I see I have medications that are scheduled that way, I'm going to basically cluster that and put that more time in the middle, so I'm not kind of going in and out all the time. Patients tend to love that. And I love it because I'm not going to keep running back and forth in this patient's room. So just be mindful of that. The next thing I put on here, I said, after all my patient care is done for the morning, mind you, I sit and chart for about 2 hours, depending on the number of patients I have. So it does take me about a good 2 hours to chart for 5 to 6 different patients, depending on the acuity of the patients. And of course, like I said, depending on how many patients I have. So if I only have 2 patients, it's not going to take me 2 hours to chart. So I'm really speaking on my patients that are, that I have about 5 or 6 patients I actually chart on every, it takes about 2 hours to do that initial charting for the for each patient, because we chart on about 9 different screens when we chart on our patients. So everything from their shift assessment to the flow sheet, to our care plan, to our I's and O's, to our IVs assessments, to our teaching that we've done. We have to update various screens on our charting. So it can take me about 2 hours. After I do that, then I work on my patient discharges for that day. So on my typical day, by the time I'm done with, let's say 5 patients, it may take me from the time I clock in at 6:45 to the time that I finish charting. It is probably now about 10:30, 11 o'clock in the morning. So mind you, I did all the things that I've just talked about. I've eaten probably. I may have got my new admission already, which means I had to stop what I was doing to include whatever her needs were. And a new admission takes a lot of time at our facility. So we're having to do different screenings for her. We ask depression screenings for her. I have to get them oriented to the room and so how postpartum works. So, we just have different things that we have to do. So they take up a lot of time. So after I do that, I work on my discharges for the day. So we have to go do discharge teaching. So once I do that, then I go check and see. The doctors don't even start coming around probably until between 8 and 12, sometimes later. So I usually go back around then and look and see if the doctors put any orders in for them to be discharged home. Now, mind you, first thing that morning, which I failed to mention, I always check to see if they are ready to go home today, meaning that for our patients, if you are 2-day vaginal delivery and nothing's going on, you're going home today. If you're a C-section that's 2 days or 3 days post-op, you have the option to go home today. They don't have to go home till 4 days for our C-section, but we usually get them out within 2 to 3 days if nothing is going on with mom or baby. So again, if they delivered on the 1st, and today is the 3rd, I'm just giving you an example, they're going home today if they're a vaginal delivery and nothing's, wrong. So therefore, I'm already going to mark them on my sheet as going home. I just need the doctor's order to say, yes, we are going home. And then I always talk to the patient. Do you feel like you're going home today? Is everything going okay today? And a lot of times the patient knows if they're going home as well. So I already kind of have a mental mindset of who going home anyway. But then I just kind of go back through and just, okay, these patients are going home. Let me see who has orders to actually go, who the doctor's already come and seen already. And I just start printing up paperwork at that point in time. So I'm dedicating that time to getting my discharges done. I'm dedicating that time because we don't have couplet care. So I still have to coordinate with nursery to see if the pediatrician has said if baby can go. If baby can't go, that changes the story a little bit. So I have to kind of coordinate my care with nursery as well to know what's going on with baby. So that can be difficult, but at the same time, I'm preparing my patients for discharge home. So I get my discharges done. After I get my discharges done, then this is something I failed to mention. We do get, it is flu season right now, and we also give the Tdap vaccine, the tetanus, diphtheria, and pertussis vaccine, as well as the influenza vaccine, as well as the MMR, measles, mumps, and rubella. I do not start my vaccinations until after lunch. So usually like my 2 o'clock rounds or so, 1 to 2 o'clock rounds, that's when I actually start those vaccines. If they're going home that day, obviously I'll get them done much earlier than that. But if I'm not going home, if they're not going home that day, then I will go ahead and get those vaccines. That includes, no, RhoGAM is not a vaccine, but I will get that done around that same time period, if that's how my day is working out for me. So typically I don't start vaccines into the afternoon, especially if they're staying. There's no point in me rushing to get that done. So I do vaccines after, with my midday rounds. And that just kind of breaks up my day for me, where I'm not feeling like I'm doing everything first thing in the morning. It allows me to kind of stay caught up on my charting and get that early morning stuff done, because typically I can stay busy in the afternoon, but I'm not doing the same stuff I was doing that morning. So I like to do my vaccines and things like that in the afternoon if possible. After I do that, then we just do our rounding, which we're required to do rounding during the day every 1 hour. However, let's be realistic. I can't get rounding done on every single patient every 1 hour, because I'm still probably assessing the ones I had, you know, and doing my follow-up assessments on my pain that I did. We have to follow up on pain in 1 hour. So I do that, and I do that diligently and get it documented. But in terms of patient rounds, every single patient, every single day, every 1 hour, I can't honestly say that I can do that, because it's just not realistic. And then I put in here as number 13 is to be ready for your new admission. Now, mind you, going back to the very beginning, that's contingent upon which number you are in that scheme. Are you first admit, second admit, third admit, or has it come back around to you again where you're getting the next admission because everybody's already got one? You know, be ready for your admission whenever that is. So maybe you may be doing this step earlier than later, but that means I have my room set up. That means my water pitcher's already in there. I've already printed off my report sheet. I've kind of looked up I've looked up this patient already to see kind of what I'm gonna have to deal with. When I do get report on her, I'm asking for a very thorough report. Again, going back to asking those questions I told you about earlier. So no, I know they should have done certain things. I'm going to say, have you done this, 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 and this? Because they know that means I mean business. That you're not going to bring this patient over here haphazard and just be a complete mess. So I need you to make sure that you have your stuff done. So I always make sure that I do that. And then after that, the last thing I do is follow up on my patient care. So I just kind of, you know, whatever I need to do throughout the day to make sure have they showered, get those vaccines done. And that's pretty much how I get through my day in terms of staying on task, staying organized, how I cluster my care. I do not like going in patients' rooms when I don't need to. And if you're a nurse long enough, you won't either. So you will learn routines or patterns or things that's good for you to get you through your shift. One thing I always say, if you are a nursing student watching this video, what I find when I do clinicals with my students is that they act like they have one patient when they really do in terms of their clinical rotation. But I said, instead of acting like you have one patient, act like you have 6 right now. Because if you have 6 patients right now, or you act like you have 6 patients right now, then you are going to manage your time very wisely. There are so many patients or so many students that I've had who we've been there since 6 something in the morning, and 10 o'clock comes around and they still haven't did an assessment. And I'm kind of like, well, why? Oh, well, she was sleeping. Oh, well, she was eating breakfast. Oh, well, the doctor was in there. All these are valid reasons. But the thing is, if you had got your stuff done earlier this morning, you wouldn't be interrupted by all this stuff. As the day goes on, more people come to see our patients on our floor. On my floor specifically, we have the pediatrician who comes to see the patient, the OB doctor, the postpartum nurse, the nursery nurse. We have somebody from management who comes around to just basically make sure we did our bedside reporting, make sure everything's okay. We have the picture lady who comes. We have the financial people who come because you didn't pay your bill. We have the DCS worker who come, or case manager who comes because of the fact that, you know, you got something going on. We have the hearing screen guy who comes to make sure that, you know, your baby can hear. That's 10. Then 11 would be, who else do we have coming? We have a person, I don't know exactly what her name or her title is, but she's basically someone who comes into our first time mom's rooms and basically offers support and help for her when she goes home. So it's a program. So that's number 12. Sometimes we have chaplains that come in. That's number 13. Who else? And then, of course, the array of dietary. Dietary comes in and bring those trays. So we have that. So that's what, number 13, 14, whatever number I'm on now. And then you have visitors, okay? So that's, you know, that's everybody else. So, of course, it's going to be like this. So therefore, I like to go in and get my stuff done. So by the time these people come in, all these different people come in, and they're annoyed, the patients are annoyed, I've already did what I have to do. So if you are a student watching this, when it comes to your clinical rotations, be mindful that a lot of people come see these patients and you are not a factor as a student. So therefore they can throw you out and you know, and say, okay, I don't want the student anymore because of the fact that they keep on bothering me because they keep on, you know, coming here asking me dumb questions or what they feel is dumb questions. And I may do a video on how to get by with taking care of your patient without getting thrown out the patient's room because they have now refused to have a student after you've already got in there, because that's happened to my students before. But a lot of that has to do with you and your attitude and how you carry yourself in that situation. So if you want to see a video on that, definitely put that in the comments below or thumbs this video up as well. But hopefully you have found this to be helpful. This is a long video, but I am very thorough as a nurse, and I've been told that by several people that I am a very thorough nurse, and that is a compliment. So I want to tell you exactly what I do when I'm taking care of my patients to make it where I am, what's the word I'm looking for? How I basically organize and prioritize my day. So I believe in a good nurse has certain attributes. They can time manage. They can prioritize. Who do I see first, second, whatever. Should I be giving this patient their Sprite or should I be charting? Should my patient who is hemorrhaging be seen before the person who, or charting should be done? Which one should I do first? You know, you gotta be able to prioritize. You gotta be able to time manage, okay? So if you have one patient, you should be done in an hour with everything. If you have one patient or one patient in my world, maybe two for a student, maybe two, but it shouldn't take you all day to get one set of vital signs. It shouldn't take you all day to do an assessment. It shouldn't take you all day to pass one med. It should be done. You have to be, you know, come in the morning ready to go, or night, whatever you're doing, ready to work, ready to go. You have to know how to do that. So that's what it takes to be an astute nurse. It's not so much knowing how to put a catheter in. That is a skill that you can learn with repetition. Starting IVs, those are skills that you can learn with repetition. I don't care if my students don't know how to do any of those skills, because they'll learn that with repetition. What I need them to know how to do is critically think, how to time manage, how to organize, how to prioritize, how to be self-directed, and how to have increased autonomy. That's what makes a good nurse right there. Someone is very much independent and knows how to take care of their patients. So anyway, I'm not going to make this video any longer than what it is, but thank you for watching this video. If you have any other video suggestions that you would like me to do, then definitely put those in the comments below. You will see my Instagram icon in the banner. It will take you to my melaninRN_MPN page, where you can follow me there. You can follow my doctoral journey over there and just different things I have going on over there. So anyway, until the next time, you all take care. Bye-bye.